on public health emergency management. For these few minutes, I'm going to focus on the current structures and legislation around public health emergency management, building off my historical talk last time. And then next, we'll talk about COVID lessons learned, and then we'll talk about sort of public health ethical considerations and crisis standards of care. So for this, to talk about where public health emergency management is now, I'm really going to look at two things. CDC's public health emergency preparedness capabilities and structures around public health response, and then ASPR's, the Assistant Secretary for Preparedness and Responses, healthcare preparedness program, and some stuff around that. Just a thumbnail on that. Within the federal agency, Health and Human Services, CDC, the Center for Disease Control, is the nation's premier public health agency. And in that capacity, it works with local health departments on public health preparedness and response. The Assistant Secretary for Preparedness and Response is a newer structure. It was really developed and built out in the George W. Bush administration, later in the Obama administration, to be a coordinated entity for medical response a little more broadly. We'll talk about what that means as we go forward. But it's worth noting that most of the stuff that underpins this got its start in an editorial by Nikki Lurie, who was then the Assistant Secretary for Preparedness and Response in the American Journal for Public Health early in the Obama administration. Dr. Lurie argued for a definition of public health emergency preparedness that really blended both of these things, that blended the health, public health and healthcare responses sort of together in terms of preparedness and response. So let's talk about how it works right now. I've got some slides for this. Let's start on the CDC side of things. So as we talked about last time, through the history of this, CDC has built up a number of structures for public health response. In 2011, they came out with the Public Health Emergency Preparedness Capability. That's 15 capabilities that together show what functions that public health ought to be able to do in an emergency. They're broken into 6 domains. You can see them here: community resilience, which works with community organizations to make sure they're ready to respond; incident management, which is focused on sort of ICS best practices; information management, as we talked about in the last lecture. Public health has a lot of data needs, hard to manage sort of all the information flow between technical audiences like doctors and the public themselves. Countermeasures and mitigation. This is both medical countermeasures, so dispensing vaccines, dispensing antivirals, and also non-pharmaceutical countermeasures, which is the 50-cent word for things like quarantine, active monitoring, the lockdowns we've seen during COVID. Surge management. So this is where public health and healthcare really blend. This is how we surge medical care when needed. And finally, biosurveillance. This is really what we think of as core public health. This covers epidemiology, disease, detecting, tracking of contacts, that kind of stuff, and also laboratory work. How do we test laboratory samples efficiently? So the thing about it is, from my perspective, looking at these capabilities, they're nice, but they're not sufficient. They have a couple of issues. A, they blend, from an emergency management perspective, different aspects of emergency management phases. Some parts of the capabilities focus on preparedness, some on response, some on recovery. So from an emergency management perspective, it doesn't kind of divide up the job the way that we like to see. Also, they focus a lot on what we do for the response itself, not so much the underpinnings of the response. If you know anything about emergency management, Quarantelli, Dimes, Drabek, they always argue that there are 2 kinds of objectives that you have in an incident. The objectives that are helping you deal with the incident, in this case, epidemiology, labs, all that kind of stuff. But then the objectives that really underlie the response itself. So that might be staffing, finance, planning, those sorts of things that keep the kind of the beast of the response growing. Capabilities really big on the incident stuff, not so big on the response stuff, the kind of mechanics you need to keep this stuff going. In my opinion, that's made for some sort of weaker public health responses than we needed. And finally, they don't cover some core public health features. Environmental health, for example, mental health, behavioral health, are not directly in these capabilities. In a 2018 update to the capabilities, they were added, but kind of on the side, threading through some other capabilities. Things like Zika things like COVID, Ebola have shown us that environmental considerations regarding waste management are really critical to public health response, and mental and behavioral health aspects are really critical to the recovery in public health responses. So those are things that really sort of need to be added. A National Academy of Sciences, Engineering, and Medicine committee that I was on was charged with studying these capabilities, looking at the underlying research base for them. And I want to highlight a couple of findings that we looked at. One is about a public health emergency operations center. So historically, obviously, the CDC stood up its own EOC. All over the country, we stand up emergency operations centers for public health responses. Unfortunately, our committee was able to find insufficient evidence to kind of recommend that. That wasn't that the committee felt like it wasn't a good idea. It's just that after reviewing 1,600 relevant papers in the journals, there were not enough that looked at the functioning of an emergency operations center. The big takeaway from that for me is if you are working in an EOC for a public health incident, let a researcher in. I know people are sensitive about it, but if you will let somebody in the door, they're going to find lessons that are going to help everybody trying to do this stuff. In the meantime, we have to say that there's not sufficient evidence to recommend an emergency operations center. That's not great for the field because you and I know that EOCs are the best thing that happened to emergencies since sliced bread. Which obviously keeps people fed well in an emergency. Really, it's since coffee. I think coffee probably more important to emergencies than sliced bread. Not as important as EOCs. But we did have a little bit of guidance we can give. When you're activating a public health emergency operations center, you want them for large, complex incidents, novel incidents that will require new tasks and partnerships. When you're coordinating with other agencies, you want to activate EOCs early on instead of waiting too late, because a lot of the benefit becomes apparent early when you're working with people, when you're bringing in additional resources. You want to stay away from them if the amount of resources you're going to need is maybe less than how much it's going to cost to actually run the EOC. That's the trade-off that you're looking for. When you're mobilizing them, you always want to listen to the advice of staff who've been through it. I know a situation that I've been through is you're in an emergency. There's a high mucky muck above you, political appointee or whatever, who's saying, well, let's not be too hasty in mobilizing an EOC. Maybe it's not that bad. Staff that's been through this grinder before will usually say, no, please, let's activate the EOC. Let's bring all the partners together. Obviously, in an EOC, you're going to have all the relevant functions that you need available, staffed, and situated so they can talk to each other. That's so helpful. Staff that have been through it will usually advocate for it, and you should listen to staff with experience. The other kind of result I wanted to highlight was about quarantine, basically because it's been such a big focus in the last few months with COVID. Looking at these, again, relevant papers, there was more data on quarantine. Most of it was from severe acute respiratory syndrome, or SARS, which was a coronavirus that impacted Canada, Hong Kong, and other Asian countries early in the 2000s, and MERS, a similar coronavirus, the Middle Eastern respiratory syndrome that impacted communities in the Middle East. These are close relatives of COVID, and there were a lot of studies about quarantine done on them. So when do you want to quarantine, folks? Early on in the incident, when you don't have other medical countermeasures. You want to weigh the resource needs against the benefits. It costs a lot of money to quarantine. And in this case, we're talking about quarantining people not necessarily at their house, but in a quarantine facility that public health is providing somewhere, maybe a congregate facility in a hotel or something like that. You've got to feed folks. You've got to give them adequate medical care. You want to make sure that the R naught is in the right range for quarantine. If something is too infectious, R naught is a measure of infectiousness. The higher it is, the more people an initial case is likely to infect. The higher the R naught is, the less likely quarantine will be of benefit because you will have already infected people. If it's too low, not a lot of benefit there either because you can monitor people. So you're looking for a sweet spot in the mid-range of R. And especially if people are going to be asymptomatically infectious for a long time, quarantine is going to be helpful because it gets those folks out of circulation. Otherwise, you can do something like active monitoring. You can call people every day. You can do symptom checks every day. Less resource intensive, but obviously less certainty that a person is out of circulation. It turns out that something like COVID is really in the sweet spot for quarantine because the 2 to 3 day period of infectiousness that people have when they're asymptomatic, that's really what's getting us. in terms of the spread of COVID here in mid-2020 when I'm recording this. Also, to make it work well, it's important that quarantine be voluntary as much as possible. As soon as you start mandating or enforcing it with security, the more backlash you're going to get. And you also need significant financial resources to mitigate harm. If people are asked to lock themselves up and they can't go to work, immediately their family starts seeing harm. You have to be ready for that and mitigate it. So these findings, if you want to Google the National Academy of Sciences, Engineering and Medicine's PhEPR study, that's the Public Health Emergency Preparedness and Response Study. PhEPR is the acronym that we love for what the field is called. You can find these things broken down on really handy sort of one-pagers for practitioners. But the most important finding of all of it ties back to what I was saying about the public health emergency preparedness capabilities. The National Academies Committee proposed an optimal public health emergency preparedness and response system that goes beyond what's in the CDC capabilities to look at both what you need to do to manage the public health threat, but also what you need to do to support the agency response in terms of staff and stuff, the knowledge and decision loop you need, kind of the planning P that you need to sort of manage your response cycle. It talks about the outcomes you want in response as distinct from the outcomes you want in preparedness, and also how you evaluate things like equity considerations to make sure your response is fair, and moderating factors like vulnerability in the population. We know from COVID, we know from hurricanes that any hazard is going to hurt the most vulnerable the most. You need to account for that and over-resource those most vulnerable people if your goal is to have the most impact on morbidity and mortality. And that sort of over-resourcing, that sort of focus on those populations is a key part of what this optimal system shows you. So that is my breakdown on COVID itself. I want to kind of jump back in to say that's sort of the CDC side of things. So these sort of public health response, looking at public health, what public health can do to support the medical surge, that's kind of the public health side of it. Let's sort of flip around and talk now about the other side, the side that's under the bailiwick of the Assistant Secretary for Preparedness and Response. So also based on Nikki Lurie's editorial, in 2012, ASPR came out with a set of capabilities for hospitals. Let me make it a little bigger so you can read it. Nope, that's making me bigger. There we go. And they essentially said that there were four capabilities that hospitals, now the healthcare system writ large, it moved from the hospital preparedness program to the healthcare preparedness program. The healthcare system needs to have a strong foundation, strong relationships with each other, coordinated through a healthcare coalition. That's a group of linked healthcare institutions that are working together to provide a best response, that they need to be coordinated well with the ESF8 lead agency. So EOCs, as you know, are broken into emergency support functions. Traditionally in the federal government, ESF8 is the health and medical emergency support function. It has different names and numbers around the country, but essentially what the capability says is there's a lead governmental agency that manages that health and medical emergency support function. Usually it's the health department, not always. And that sort of governmental coordination needs to reach deeply into all of these healthcare institutions, including places like primary care, including places like nursing homes, especially where we often see a lot of mortality. The third capability focuses on continuity of healthcare service delivery. Can they provide uninterrupted care, even in something like an earthquake or a hurricane, when there are impacts to the healthcare sector? And finally, the fourth capability is about medical surge. When more care is needed, and now we're looking at pandemics or terrorist incidents where you're going to have a lot of wounds quickly, can the healthcare system surge up? Can it discharge folks who are non-urgent? Can it provide more care, more staffing, more resources to meet the additional care needs? So those are kind of the baseline capabilities from ASPR. Now, the way that worked is ASPR HHS has divided the country up into a number of regions. You can see them here. The idea was that every region, or the idea is that every region will build up a healthcare coalition. And that coalition will be in charge of the linking between healthcare institutions individually and the sort of governmental health and medical emergency support function writ large. That's kind of the structure of how coalitions were supposed to work. Now, the ASPR that was appointed by President Trump added a new set of structures to this healthcare preparedness program. And they were based on a regional healthcare system here. You can see the goals of this regional healthcare system. The idea was that beyond the sort of local healthcare coalitions, you couldn't resource every hospital in the country to deal with really severe pathogens in something like a bioterror outbreak, but you could resource some of them. So why not link these coalitions together into a regional approach and have best practice hospitals that would serve as sort of to coordinate the regional medical response, since as we know, disasters don't respect jurisdictions. So this pilot program was building up a regional approach, expanding specialty care in certain specific hospitals, giving them the ability to coordinate a regional approach, and making sure that their preparedness was being measured with evidence-driven criteria. This was based on some of the work we talked about in the last talk about Ebola. After Ebola, the federal government funded certain Ebola treatment centers. This is the Regional Ebola and Other Special Pathogens Treatment Network. The triangles that you see are regional specialized treatment centers. The circles are sort of surge places that could treat for Ebola. So the idea here is that every hospital should be able to screen and isolate patients with a special pathogen. Some hospitals were given funding to be able to treat those pathogens, isolation rooms, negative pressure rooms, special training for their clinical staff. And only certain hospitals were really there to be regional hubs who were real specialists who needed to show leadership in the response and also take on sort of the special cases, the initial diagnostics, that kind of stuff. Here's how it's supposed to work. This is from the Massachusetts conceptual framework, but it kind of describes generally how the program functions, which is on the left, you've got an event. So we're looking sort of right of boom after that. First, you've got to coordinate pre-hospital care for the event victims. Some of those are going to go home. They're going to go to clinical outpatient facilities if their injuries are not that bad. Others are going to be transported initially to a hub hospital. This is all pretty normal for pre-hospital care so far. What happens at that point is you've got hospitals that are designated as hub hospitals. They're going to receive these patients, and then other hospitals that are spoke hospitals. So what this means is that EMS or the hospital system itself has to do secondary transport, which is something that EMS doesn't often do, right? Pre-hospital care goes from the scene of event to a hospital facility. After that, though, this is adding a new wrinkle, a secondary transportation wrinkle, which is going to take those inpatients from that hospital, possibly to an alternate care site, like a federal medical station, possibly to a spoke hospital, to do bed balancing, or because they have specialized treatment arenas, or to a long-term care facility, or possibly even out of state if a regional specialty hospital is needed. So when you look at ASPR and look at CDC, what you've got is on one side the core public health elements of the FEPR system, the Public Health Emergency Preparedness and Response System, and then on the other side, the core healthcare elements of that. Both of them do things like surge teams, right? So the CDC coordinates DMAT teams, disaster medical assistance teams, as well as teams around things like environmental health or epi diagnostics, those kinds of things. Health department in a box teams that can go in and provide assistance to a health department impacted by disaster. On the ASPR side, they've got federal medical stations. So you saw the video about the Javits Center that was set up in New York City. That was a federal medical station that was set up based on the playbook that ASPR's developed about that. Both of them also coordinate voluntary health professional programs. ESAR-VIP is the acronym on the ASPR side. That's for the a registration of voluntary health professionals. On the CDC side, you've got the Medical Reserve Corps. That's a group of professionals who are willing to jump in and help with public health incidents. So healthcare, two sides of the same coin, but they really have to work together well to achieve that optimal public health emergency preparedness and response system. And the thing I'll say about this, the complicating factor, is that in the United States context, in an emergency, we ask government to do something that's really difficult. Our government day to day is really based on being minimal, right? Staying out of the lives of private citizens, supporting individualism, kind of empowering people to just live their lives. But in an emergency, a lot of the scholarship says, boom, We want folks in the government to suddenly switch roles and become kind of all powerful. This leads to a lot of the difficulties in emergency management because we are asked to do things in an emergency that we're just not structured to do. This comes down to federalism. Unlike Great Britain or New Zealand or Australia or whoever, we don't really have a unified national response, except in very rare circumstances. Our responses are locally coordinated, supported by the state, then the state is supported by the feds. You learn this in Emergency Management 101. It's great in a lot of ways because it lets disasters be coordinated locally by people that know the situation best. But it isn't great in situations where you need one sort of unified response around the nation, which is what you often need in public health. And it's really tough in healthcare because it's not just that every jurisdiction is making different decisions. We have a privatized healthcare system. So that means every healthcare institution is a competitor with every other healthcare institution. They're all fighting for the same patients, and they're all using sort of practices. We cost less, we're better than those. You're using these competitive practices to bring in patients. Suddenly, boom, in an emergency, we have to flip that switch, and we want them all to work together as a healthcare coalition. A lot of great work has been done by ASPR and its states and cities around the country to help that, but we're still fighting against the core DNA of the healthcare system in doing it. So the coalition model that ASPR is proposing is really important, and it's really difficult. In COVID, we saw lots of regional networks of care stand up, but a lot of times they stood up in places that had been fighting them for years because they were worried that they would amount to some kind of public take of the healthcare system. That's why whatever you want to say about single payer Medicare for all, as a public health emergency manager, I'm jealous of something like the UK's National Health Service, because at least it lets you provide a coordinated approach to an emergency response, which is something emergency managers at EOCs all across the country are always kind of fighting to do. And the healthcare system makes it much more difficult. So that's the end of my summary of where the field is right now. Next talk, I will talk specifically about COVID and what we've learned so far here in mid-2020. Thanks so much.